Well, So, sort of a weird topic because my worst case would be one that ruptured, and that's not really something you really want to see because basically probably used a big balloon and the patient got their chest cracked. So that's my worst case. So what I'm going to show you is actually how I deal with central venous renal canalizations and basically two sort of complex interventions to basically connect these people. So this is sort of my setup. I call it the come to Jesus prep. You know, supine, both upper extremities, abducted 90 degrees, and groin axis. So not necessarily both, but depending on if it's only a right arm symptoms. But basically, this is sort of my generalized prep. I don't know if you guys get these slides, but this is basically my toolbox. Micropunctures, hydrophilic wires, angled catheters, balloons, and stents. We typically try not to go over about 14 millimeters. We actually don't balloon much more than 12. And then the reason for that is as you start getting bigger and bigger, your bailouts become more and more difficult. So that's sort of my size cutoff. In terms of other things, if you do run into clot, some sort of way of getting rid of the clot, so thrombolysis, thrombectomy. We have, I can't remember the last person we actually did overnight lysis for upper extremity DVT. We use a lot of angiojet here. Obviously, if you're doing upper extremity DVT work with the angiojet, you do have to be a little bit careful as you bring it closer to the heart. You can end up with symptomatic bradycardia. We actually have seen the patient go down pretty darn close to zero, so you just got to be careful. And then sharp recanalization. Cook makes a 65 centimeter Shiba needle, which I'll show you in a little bit, which you can actually put intravascularly. You can make your own Rosh-Hashida needle. You basically tie it, you cut a 65 centimeter catheter to a little bit shorter. You can actually then introduce the needle and a catheter as a unit, and you can use that for sharp recanalizations. You can actually put O&8 wires through it. And you can, like I said, you can use a Rosh-Hashida needle. The problem is the Roche needle is a little bit short. So if you're coming from a very close distance, it works, but if you're coming from a longer distance, it's not so great. So this is a case, again, most of the time this is not what I do. Most of the cases we end up doing, it's just a catheter wire, sometimes a little bit advanced, be the back of a wire. But this is a patient who had severe right upper extremity swelling, actually has an AV graft here, which is coming through here. And what's happened is the right brachiocephalic IJ is out, and you can start to see the beginnings of the infraazygous SVC. So we got a pretty decent distance to do it. So we tried with a wire and coming from above and from below, and we could not connect the two of these things. And we were really hoping, this patient, obviously needs us for dialysis. If we bail on this, the left side was actually already out. So, you're looking at probably groin lines or a groin fistula. So we figured we'll just give this a Hail Mary and see if we can fix this. So what we did is what we call a Gunsight technique. So what we've done is we got as far up from the upper extremity access and as far over from the arm access. We basically put a snare on each side. So you have a snare from below and a snare from the arm. And what you do is you basically turn the II until both of them are en face. So this is the snare coming from below, and this is the snare from the arm. And then what I've done here is basically, you can kind of see, we've percutaneously passed a needle through both of them. Obviously, we don't do this just sort of blindly with blind faith. We did do an ultrasound on the table to make sure we're not passing through an artery. This is actually just the micropuncture needle, so it's about a 5.5 centimeter throw. Again, what we do is, as we're pushing the needle in, we're aspirating to make sure we don't get a flash from the artery. So then the next step is to figure out how to do this. So basically, to reverse this. So this is a V18 wire percutaneously through, and we snare that out from the groin. So before I show that part. So what we have is basically through the skin and through the snare in the arm, we have this V18, which is then the distal end is out the groin. But we can't really snare the back end of the V18 because obviously you're going to pull the sharp end of the V18 back. So you need a way of reversing this to make it a workable situation here. So what you do is you actually pass a microcatheter up from the groin back up. You can create a rail to get it to go. And basically what I've done is actually the microcatheter is nearly out of the skin, and we snare the microcatheter out. Once the microcatheter is out, it's basically the front end is out the front end is out the arm, and then the hub is in the groin. Putting the V18 back up, I can balloon and then stent, and I've created a rail. And what we did here is we put because it is a high flow situation, you could put a self-expanding balloon, regular bare metal, but we put a Viabond here to make the bend. We actually ended up clearing this out. We didn't have the run. We just had a fluorosave. And that patient did well. The other thing we've done a couple of times is the situation where you end up really close, like really, really close, but you just can't get the two to connect. And so here's a situation. This patient presented with basically severe right arm swelling. The IJ's out, brachiocephalic, part of the subclavian's out here. And we were able to, again, from the groin, we could actually recanalize into the IJ. And from the arm, we could only really get over the IJ. We couldn't actually get the two to cross over each other. So you can see here, we're close, we're trying to push the wire. We really couldn't get it to flip down. Sometimes we'd end up in the mediastinum. You can see, I don't know if you can see that very well, but you can see the stain from previous injections of trying to recanalize this from the arm. So what we do is sort of an old trick, but basically this is a, I can't remember if it's an 014, basically a balloon from the groin, and we use the outback basically to puncture the balloon. You can see here, you'll see the little bubble. When the outback needle's down, the bubble's out. So the needle's actually into the balloon. What you're able to do then is push the wire through the outback. So it's an 014 wire. You actually, as you're pulling it, you actually spin the balloon, put a little twist on the balloon. The wire will get caught inside the balloon, so acting sort of like a snare. And you're able to pull that out, snare it out, and we're able to put this, again, once you have the wire access across, it's a matter of ballooning and stenting from there. Again, central venous occlusion, so can be life-threatening and require urgent intervention. Having the right tools is a must. You need the right-sized balloons and stents, as we talked about. Tools for sharp recanalizations can be helpful. Again, if you're going to partake in that, I do recommend having some sense of preoperative imaging because you don't want to get yourself in trouble. We have seen cases where the arteries and the veins are flip-flopped or very close together. Know what your bailout's going to be and like what you have available to you to bail yourself out if you do end up with a mediastinal bleed or a hematoma. We've had pericardial bleeds, and a lot of times it's not so much that you have to fix it, it's more so being able to recognize it very quickly. And again, we do a lot of these cases, almost all of these cases with anesthesia, so they're very helpful to us in terms of telling us, the shit's hitting the fan, so you gotta look for something. So again, we start with the simple angled catheters, glide wires, and guide catheters. I would say 80% of our cases we're able to complete with that. We don't necessarily need all these fancy techniques. Sometimes sharp recanalization is just the back end of a wire just to get that last little pop. Needles are helpful, as I showed for a Gunsight. You can actually pass them through intravascularly, snares and outback. There are newer tools like the RF wire. The problem for us is the RF wire lives upstairs. You have to put the Zoll pad, the grounding pads and stuff like that, so we don't necessarily use that. It is a good wire. I know the guys in South Carolina have a huge experience with that in terms of using the RF wire, but we can't really talk about that right now. So, thank you.